Tumor of the bladder. Papillary tumors. Cystoscopic inspection does not disclose the malignancy of a papillary growth in the bladder. Inflammatory ulcerations, whether encrusted or not, may well be papillary, but such papillae are relatively short and are distributed over a relatively large bladder surface. They are obviously not neoplastic. The papillary neoplasm, if small, is seen as a tuft of villi growing from a tenuous pedicle. The large papillary neoplasm is likely to have a cauliflower-like appearance, the villi being packed so close together as to appear fused in bunches. Such a large neoplasm may more than fill the cystoscopic field and bleed so freely as to obscure the diagnosis. The villi also choke the sheath of the cystoscope and interfere with irrigation. Such tumors are often multiple. The ulcerated papillary tumor. Spontaneous ulceration of a papillary tumor usually means that it is malignant. The ulceration covers more or less of the surface of the growth with a white slough to which phosphatic grit is likely to be found adherent. The non-papillary ulcerated neoplasm. Carcinomatous ulceration of the bladder wall cannot be readily distinguished by inspection from inflammatory ulceration. Inflammatory ulcers usually appear about the trigone and bladder neck, while malignant ulcers affect the vault and fundus. Secondary carcinoma of the bladder. Carcinoma invading the bladder from the prostate, the uterus, or other adjacent organs is discovered by other means than cystoscopy, but the cystoscope measures the involvement of the bladder wall. The earliest change, excepting growths coming from the prostate, is fixation of the bladder wall at the point of invasion. The fixation may sometimes, though not always, be recognized when the bladder is fully distended by wrinkling or dimpling of the surface drawn to one side. This fixation, in cases of tumors extending from the uterus, is likely to show itself in the fundus, just back of the ureteral orifices. As the carcinoma extends further into the bladder wall, the surface of the mucous membrane is thrown into red edematous folds. The picture shows a circumscribed region not unlike chronic cystitis in appearance. Ulceration does not occur until infiltration has existed for a considerable time. Bullous edema or vesicles may appear early. Plate 1, Figure 5. Non-infiltrating neoplasms. Under this term, we include the non-malignant myofibroma of the bladder wall itself, and such tumors of the adjacent tissue, whether malignant or not, as depress the bladder wall without invading it. Such tumors are recognized after full distension of the bladder by the fact that they project more or less markedly into the bladder cavity, and difference in distension does not materially alter the position of the point of projection. The mucosa over such projections may or may not be inflamed. Plate 1, Figure 4. Cystitis cystica. This condition is recognized as a scattered or grouped collection of pearly or pink vesicles distributed over a more or less reddened surface of the bladder. Figure 4, depression of the fundus by extravesical carcinoma of uterus, cystitis. And Figure 5, invasion of bladder wall by uterine carcinoma, no cystitis.